I prepared a presentation about the laser. These are my conflict of interest. And I started my presentation with this slide that is a little bit provocative because laser is only a tool for enucleation. And before speaking about the laser, we have to know that there is an important role of the technical technique and most important role is the surgeon. So take care because if we could do the enucleation with the finger, we can do the enucleation with any kind of energy. But we are speaking about the laser today, and the laser is moving in another way to remove the prostate because we are coming back to the open surgery. So with doing the prostate enucleation, we are coming back at the original the original technique, and this is the technique that is removing all the prostate. And when we speak about the different technique, we have mechanical technique now. I think that we Urolift and we saw a lot. We have an extra anatomical surgery, and we have the anatomical surgery, and anatomical surgery is enucleation. And regarding all this technique, we have also to evaluate the PSA, and the PSA is the direct confirmation of the removal of the tissue. And we can see that in enucleation, in open surgery, we remove all the prostate, all the tissue, the prostatic tissue. When the other mini-invasive surgery, we don't remove sometimes tissue, but we remove only few part of the prostate. So it's different option with different result. And if we consider resection, vaporization, and enucleation, we have different winner. And you see QRP is the best for resection, vaporization for green light, enucleation with different kind of laser or other kind of energy. Green light has a role today. I think that is less than in the past, or we would expect for this kind of laser, but in some particular patient, especially in patient taking drugs for anticoagulative therapy, this is today one of the most important indication. We can have also another kind of laser is the continuous wave laser. In particular is the thulium-YAG laser, and this laser has a role for enucleation also, but without the possibility to do a real enucleation, because this laser is only cutting. You have to use this laser attached to the tissue. So this is really important. And we move to the endoscopic enucleation, and I started all my presentation on enucleation with this paper of Thomas Herman, because enucleation is enucleation. So you can do enucleation with any kind of energy sources, and it depends on your technique. And you can change your technique, but you can remove the prostate with any kind of energy. And we can do this with a blunt dissection, mechanical dissection. We can do this cutting and vaporizing, and we can do this with the real enucleation. And this is the concept of macro dissection of the adenoma, or the micro dissection due to the photomechanical effect of the laser. And in my personal opinion, I prefer this micro dissection, this energy-driven enucleation of the prostate, because it's for sure more precise, more nicer with the tissue, and also following all the anatomical details of your enucleation. And we were asked to do as a referee of this debate about the laser. We concluded that as usual, you have to know your laser, you have to know the technique that you have to use in this laser, and at the end, these three different papers done by Thomas Herman, Fernando Sancha Gomez, and Dmitry Enikev with three different lasers, at the end, we couldn't arrive to define the winner, the best laser, because at the end, as we told many times this morning, is also about the surgeon and the technical features that we are use. And when you speak about the laser for a soft tissue, you have to see the versatility. And yesterday, Olivier put this presentation in which you can use the laser for stone, for holmium, thulium pulsed laser, and thulium fiber. And if you consider the versatility of the laser, we have three lasers in the market. One is the thulium young pulsed, the TFL, and the holmium. We have also the other laser, diode laser and green light for the enucleation, but is important, especially in the small hospital, in which you can buy only one laser to have this versatility to treat stone and soft tissue. Regarding the holmium, we have really a lot of machine. This kind of laser exists more than, I think, 30 years. And the wavelength, you know exactly the parameter is absorption is in the water. For the holmium, we have to focalize our attention on the peak power. The peak power of the holmium is from 2010 to 12,000 watts, and this could be really important to understand the clinical effect, and with this very strong photomechanical effect. TFL is in the market since 8-9 years, and is a little bit different. The most important characteristic comparing with the holmium is that it is more absorbed in the water, less penetration depth, and also lower peak power. And also this laser you have to know very well, because also for using this laser, for example, in soft tissue, you have to stay closer to the tissue, as you see in the procedure of Dimitri today. So this is another laser with other characteristics, able to do everything. And the third one is the new kid in the box. Last year was born in the market, and was a sort of survival of this thulium YAG because of the versatility. The pulsed thulium YAG give the possibility to the thulium YAG to survive, because now we can use also this laser with the stone. We have different peak power. If you consider, for example, the Dornier and the Lisa, there are totally different peak power. The reason is that this laser is not really a pulsed laser, but is a modification of the single pulse with these control chops on the laser. So they modify is a continuous laser, and sometimes you have this pulsation, but it's not really a pulsed laser. And when you think about the interaction of the laser, you have to underline the absorption, the transmission, the scattering, the reflection. These are also important because, especially for the holmium, we have a lot of energy that we can't control. And my impression is, as Dimitri told before, that with the TFL we have a more precise control of the laser. This is very important, especially, for example, when you have to cut around a bladder tumor to do the en-bloc. And this is important to know. This is important to do the precise setting of the laser, because we have to know that the laser has different characteristics, especially in the creation of the bubble. If we consider the holmium in the last 4 or 5 years, we have this pulse modulation. The pulse modulation means that you have different kind of bubble. Look, and the quanta vapor tunnel, virtual basket, and bubble blast, and the Moses is a totally different bubble, and with the totally different clinical effect. And this is really, really important. And also this effect, the different setting give you the possibility to have a different penetration depth of the laser, and consequently you have also a different distance from the tissue. And you have to know this, and you have to know that, for example, for TFL, if you don't stay close to the tissue, you don't have any kind of effect. But I want to underline, and I want also to discuss today, if it's possible, this concept, because I try to do my best to lowering the power of the laser at the minimum with the same efficiency in terms of enucleation efficiency, in timing. And I think that this is very important, and for each kind of laser I am using the less energy and frequency, the less potency that is possible to reach the same efficiency. Is the putting the concept of the ALARA that we have in X-ray also in the laser. Because we have to take care to what we give as suggestion, especially in the learning curve, in the young urologists, because we are experienced surgeons. We can see directly on the screen the effect of our laser, modifying the distance from the laser, but when you start, you are not able to do this. And you are giving a lot of energy. So what we did, what we said with Dimitri this morning about a sort of speed limit for the training, I think that is mandatory to avoid these irritative symptoms that when you have these irritative symptoms are very, very difficult to be treated for the patient. This burning that the patient has under the scrotum in the perineal zone is really due to this, and is impossible to see this complication during the surgery. And we have a new kid in the box, and I think that we have to underline this kind of laser. This is an holmium laser, is the Cybero Quanta, and the difference from the normal holmium laser that they try to reduce the peak power. So we have in the same laser now a peak power from 500 to 12,000. So we can have two lasers together. So we have a laser with similar characteristic to the TFL. So this is really important in my opinion. I think that also is, I think, one of the most expensive laser, but you have both laser and both clinical effect that you can have if you have in your hospital the TFL and the holmium. And this is the magneto of Cantor. You will see this laser in my surgery after this presentation. And I put again another slide of Olivier of yesterday regarding the presetting, because if you write your presetting in a machine, you are responsible of everything happen with this presetting. So what I'm really sure that we can't suggest to use this laser with 3 joule, 4 joule, high power, 120 watts, because if you are not able to drive your machine, you have to go really slowly. You can't get a Ferrari the first day and go 250 kilometers hours. So it's the same, and the problem is that you can't see your damage on the patient. You see the damage after the surgery. And this is really important. At the end, I think that is very important to discuss with the patient, to listen to the expectation of the patient, and to tailor the treatment. And I want to underline that it's very important before the surgery to do a ureterocystoscopy, because you can have different length of the stricture in the prostate, in the bladder neck. You can have a middle lobe. You can tailor your treatment, maintaining, for example, the ejaculation, and give to the patient a very good mituration. So thank you very much. This is the Congress that we will organize next November in Torino, the 14th edition of the TNT. And if you want, you can come, but it's also possible for free to be connected via web for 3 days. So it's only to register. Via web is completely for free. Thank you very much.
Just a question, Dr. Scoffone. Talking about enucleation, could you recommend a laser depending on the size of prostate? For example, big prostate.
If I have to give one preference for me for a big prostate, and big prostate is more than 120 grams, I prefer holmium. Holmium for this photomechanical effect, because make the surgery faster. Yeah. So in my personal experience with TFL, we have 10 to 20% more time, but if you have a prostate of 50 grams with holmium, could be 20 minutes, and with TFL is 24. But if you increase and you have 1 hour with holmium, is 1 hour and 20 minutes with TFL if the prostate is very big.
And Cesare, talking about the coagulation, you can obtain a good coagulation with any laser.
Sure.
When you finish the procedure, when you finish the enucleation, you can obtain the final coagulation spending time. Do you prefer, when you have treated a very big prostate, to use a bipolar coagulation because it's faster, or not?
Yeah. You opened the door, because I am the only one that I'm using always bipolar instead of the laser to coagulate. If you spend 5 minutes with the laser or 5 minutes with bipolar, I think that is no difference. But I want to underline that with the enucleation with the laser, you have to avoid the coagulation at the end. With the laser, it's very important to do the coagulation during the enucleation. And you can modulate this with the speed and the distance from the tissue regarding the different laser. And I think that reducing a little bit the speed of enucleation, you can coagulate better during the enucleation. So at the end, you have to coagulate, but not a lot of vessel. If you do faster the enucleation, also with some blunt dissection and not energy-driven dissection, you need at the end to coagulate. And in my experience, I have bipolar in my table in the OR. I change the working element. I think that there is no needing to use only the laser. It's like the example that I'm doing also the nuclear section of the kidney tumor. I'm using ligature, I'm using bipolar, I'm using monopolar, depending on the step of the surgery. So I think that the same we can do with the laser enucleation.
And the last one, do you obtain the similar coagulation independently of the laser that you are using?
Is more difficult to do the coagulation with the holmium, especially with the short pulse length, because the peak power gives to the holmium this photomechanical effect. And if you stay too close, instead of coagulating, you have the photomechanical effect instead of photothermal. So you push the artery instead of coagulating the artery. So it's easier to coagulate with the laser with lower peak power, like TFL or holmium, but with a very long pulse length and a short peak power.
Okay, thank you very much, Cesare.